I will be presenting on integrating psychological aspects in ACL prevention rehab. And I would like to start, sorry about that, to acknowledge the funding sources that have supported the project that I will present today. I would like to start by asking this question: is current best evidence treatment for knee injuries good enough? And as Hege said in her talk, the first thing is to actually do the rehab in the first place. But studies show that although people have done rehab, they still report poor knee function, fear of injury. There is persistency in sensory motor deficiency with reduced strength, reduced hop performance, undesirable movement quality. And we know that, as Hege also said, that it's important to improve and restore muscle function, as this is associated with higher likelihood of return to sport. But we also know from studies that although people do reach normal muscle function, only about half return to activity or to sport. So given this, we can ask ourselves, can we optimize treatment? And if so, how? If we go to best evidence treatment, it includes, and this is nicely summarized in a review by Phil and Grindem. It's focuses on physical function with neuromuscular and strength training to reduce joint diffusion, increase range of motion, and improve muscle function. They also state the importance of addressing psychological barriers to sport activity participation. And they state that there is a need for research on interventions to improve psychological readiness to return to sport. So why are psychological factors important then? Studies report that psychological factors such as higher self-efficacy, reduced fear of re-injury, greater satisfaction with knee function are associated with better knee function and higher likelihood of return to physical activity sports. Studies also report that in uninjured people, psychological interventions both improve psychological outcomes and increase central nervous system activation. And it has been suggested that a knee injury represents not only a musculoskeletal injury, but a neurophysiological dysfunction which may result from damage to the somatosensory system. So it's not just about the joints and the muscles, but also about the brain. So what about the patient? They may also have a focus on improving their physical function when they go to rehab. But there is also a lot of other things going on in their mind. Things like, and thoughts like, will I be able to return to sport? I want to return to sport, but how do I get there? Frustration, anxiety, pressure, like the coach and the team wants me back soon. Rehab is boring. I'm struggling with the injury and the rehab. I have fear of symptoms and re-injury. So taken together, what the patients perceive and with the neurophysiological dysfunction, we ask ourselves, if we integrate psychological factors in current rehab, can we improve objective and self-reported outcomes? And can we increase motivation, enjoyment, and patient ownership of rehab? So we are an interdisciplinary team of researchers and clinicians within sport and exercise medicine and sport and exercise psychology. We have developed a model that we call motor imagery to facilitate sensory-motor relearning, or MOTIFS. And the popular science title of the project is Train the Brain. So if we look into the literature with ACL rehab intervention, you all know that focus is on physical perspectives. And I haven't even listed them. And as Hege showed in her presentations, there are over 4,000 publications on rehab. And rehab is included whether or not you add surgical reconstruction of the ACL as treatment. But if we look into the literature when it comes to psychological interventions with knee injuries, we found one systematic review. It includes 4 small studies on psychosocial interventions in addition to knee rehab. And the interventions are either static guided imagery and relaxation, or that the patients watched coping or therapeutic videos. And from only 4 studies, it's difficult to draw any conclusions, but it appeared that such interventions can improve self-efficacy, but the evidence is not very clear when it comes to fear of re-injury or re-injury anxiety. And in these studies, the patients were in rehab, but the interventions were separate. So in contrast to having separate interventions, in MOTIFS, we have a holistic approach where we integrate psychological and physical aspects into current training programs, taking into account the localized physical trauma, central service system changes, and overall psychological aspects of the injury. And today it's not known what interventions, psychological interventions that work in people with injury. We decided to use imagery, which is the practice of using one's own memories and experiences to create a mental picture of a situation. And motor imagery is applicable in this context. It can be divided into static imagery, which is focused on contextual, tactical, and kinesthetic aspects with little or no physical movement. For example, when you sit in a chair and imagine a movement without moving. And then we have dynamic motor imagery, which is imaging a specific situation while simultaneously physically mimicking part or all of the movement in order to increase realism. And dynamic motor imagery is what we have decided to use, as it aims to improve performance by creating a functionally equivalent image of a relevant and activity-specific movement. And imagery is actually a natural mechanism. Kids do it a lot. And this is a typical example. I think you can imagine the kid here thinking about being messy, playing at the World Cup final. It's the final minutes and he scores a goal and the crowd is cheering. So, and this is, imagery is actually something that adults do too, although we don't talk while we do it usually. But another situation is that you can see is a downhill skier before they go for the race. They're waiting and they actually do the movements and just the minutes before they do the actual race. So using this, the principles of MOTIFS model are the following. The key is to integrate imagery into rehab exercises. And the first thing is to discuss a scenario with the patient based on the patient's own experiences. And then the physio and the patient creates the exercise together. And it needs to be an exercise that is individually relevant, realistic, and meaningful. The patient then executes the exercise with relevant equipment and context-specific execution. For example, follow-through movement. I will come back to that. Technical and tactile aspects. And then the physio and the patient evaluates the exercise, modify and come back to the scenario, and so on. And the level of complexity when it comes to the imagery can be modified within an exercise and also over the course of rehab. And we emphasize the importance of maintaining proper movement quality because that is something that we as physios believe is important. I'm going to show you some examples of exercises. This is a toe-off exercise. First, you will see the care as usual execution and then the MOTIFS condition. So here the participant focuses on fully extending the knee and pushing up onto the toes while maintaining good posture throughout the movement. Here we have the MOTIFS condition, and this participant is a soccer player, so therefore the exercise is adapted to her. First, they discuss the scenario, create the exercise together, and decides that the participant, while she does the toe off, she focuses on reaching up towards the ball, thinking of where to head the ball, what the arms are doing, and scoring on the opposing goalie. In our project, we set two main hypotheses. The first was that athletes will report higher self-reported enjoyment of physical activity following MOTIFS training compared with a training session using established knee injury prevention and rehab training principles. And the second is that 12 weeks of rehab with integrated dynamic motor imagery will improve patient-reported psychological readiness to return to physical activity and objective muscle function to a greater extent than care as usual rehab in people with traumatic knee injury. And the first study is a crossover experimental RCT. It was recently published in Journal of Science and Medicine and Sport. We included 30 athletes active in ball sports. They did 4 care as usual and MOTIFS exercises in a randomized order. And we had a number of patient-reported and objective outcomes. I will come back to these because these are questionnaires mainly that we as physios don't very often use. First, give an example of an exercise. This is a complex movement that was included in the study. First, the care as usual condition, where the participant focuses on correct landing and push off to absorb and create power in order to maintain posture and control in a dynamic movement. The same exercise, but applying the MOTIFS principles. They first create the scenario or discuss the scenario and create the exercise. And then the participant focuses on dribbling around an opponent and where to next pass the ball. And in the publication, there is a MOTIFS explanation film as supplementary material, and it's open access, so you will be able to download it there if you want to see more exercises and more about the model. In this study, the physical activity enjoyment scale was our main outcome. It measures the extent to which an individual enjoys the physical activity. It includes 18 items scored on a 7-point Likert scale. And just to give some examples of the questions, you score the extent to which you enjoy or hate the exercise, whether you feel bored or interested, absorbed, not at all absorbed, or whether the physical activity makes you depressed or happy. Then you receive a total score from worst to best. And in the study, we found that the participant enjoyed the MOTIFS condition a lot more than the care as usual condition. This was well above the clinical relevant difference, which is 7 on this score, and our difference was almost 24. The participants also scored on a self-assessment Manikin. It measures 3 aspects: valence, which is the emotion, a positive and negative emotion of the activity. So you score on this scale, a 9-point scale. They also score arousal, how active or passive they feel during the activity. And they score dominance, whether they feel controlled or in control. And also for this score, we found that it was more positive, they were more active, and they were more in control in the MOTIFS when they did the MOTIFS exercises compared with the care as usual exercises. As for the other secondary outcomes, perceived exertion and heart rate were higher in the MOTIFS condition compared to care as usual. MOTIFS took, however, longer because you discussed the exercises with the patient or the participant. But movement quality there was no difference between the conditions. So the conclusions of this trial was that the MOTIFS model is a plausible method for influencing patient-reported outcomes, such as enjoyment, using interdisciplinary and person-centered principles to integrate simultaneous psychological and physical training in knee injury prevention and rehab programs. And integration of the MOTIFS principles into physical training is vital as a distinguishing factor compared to other studies, which apply separate physical and psychosocial interventions. We have a clinical RCT running where we will include approximately 100 patients with traumatic knee injury. They all undergo physical therapist supervised rehab. And in this study, they are included when they have reached the stage of rehab, including single leg hop. And they all have a goal to return to physical activity or sport. The intervention is 12 weeks, MOTIFS or care as usual, so randomized to either model. We have physical therapists providing the intervention, and they have attended a 5-hour workshop, and they have received educational material for the MOTIFS model. And we also have a sports psychologist who has 3 face-to-face meetings with each patient. And an example of a complex movement, this is a typical care as usual exercise. I think this is something that you all will recognize, something that you use in the clinic. So a shuttle exercise. And this is, as you can see, the late phase of rehab. Well, here we have, it's not the exact same exercise, but a complex movement applied to a floorball player. So first, the physio and the player, they have discussed the scenario, created the exercise, and then she focuses on moving around an opponent as well as thinking of whether to dribble the ball and look for a passing opportunity and passing the ball. So creating realism. We have decided to have two main outcomes, one patient-reported ACL return to sport, and one objective muscle function, the side hop test. We have secondary outcomes, some patient-reported outcome scores, physical function. We measure adherence and follow adverse events. We also perform interviews with both physical therapists and patients about their experiences of rehab. And so far, we have included about 1/3 of the patients in the trial. And we hope that the study protocol will be published soon. So what about the practical implications of this model? Well, based on the first trial, the experimental RCT, we would like to suggest that holistically integrating physical and psychological aspects into injury prevention and rehab training is a plausible method of influencing patient-reported outcomes. The MOTIFS model can be used by practitioners through athlete discussions to simultaneously, physically, and psychologically simulate individually relevant scenarios involving athletes in decision-making and exercise design. And integrating dynamic motor imagery uses sport-specific equipment, expertise, and goals to create a single training exercise which enhances enjoyment without compromising movement quality. And when it comes to effects on the injury rehab, we'll just have to wait and see for the results from that study. Thank you very much, and I'm happy to answer any questions or discuss with you. So you can either email me or contact me on Twitter.